So, one more case, ACL reconstruction. So, she is a female of 45-year, active lady. Presented to me 3 months back, there was a knee injury, fall from two-wheeler, and presented with pain, recurrent locking and instability of the knee. An examination, range of motion was full, latchman positive, joint tenderness lateral side, no collateral laxity, and 2.5 centimeter vesting. The MRI show ACL injury and complex tear of lateral meniscus. We decided to go ahead with the ACL reconstruction and meniscus procedure. So pre-op investigations were normal. It was just after the second wave of the COVID, so it was routine practice to go for the COVID RT-PCR, which was negative. So left ACL reconstruction done using hamstring tendon, endo button fixation on the femoral side and bio screws on the tibial side. And partial lateral meniscectomy was done. So post-op period, on 10th post-op day, I got a call that patient is presenting with a fever with chills. We called her. There was a swelling and pain in the knee. Aspiration was done, sent for all these investigations, culture sensitivity. Blood investigations were done. And these are the investigation. Total count 9,600, ESR 82 and 1112, CRP was 184, and the COVID RT-PCR was positive. So this, please put the RS question 1. What we would do? We'll ask the physician to take care according to COVID guidelines, start oral or IV antibiotic, or you offer arthroscopic lavage. Okay. So, since the culture was negative and the COVID was positive, I asked the ID specialist to take care of her. So there was a high-grade fever with breathing difficulties. On 13th day, she was admitted in ICU. Corticosteroids and remdesivir were started. On 19th post-op day, there was severe pain in the left knee and swelling was increasing. The blood investigations, the culture was still negative. So on 20th day, I did arthroscopic lavage and debridement. The graft was intact, cartilage was normal. The IV antibiotic, cefoperazone, sulbactam started. After the debridement, there was every day 2 spikes of the fever. The pain was a little bit reducing, but there was 2 spikes of high-grade fever post-operatively. On 27th day, she presented with a severe pain in the left knee. And persistent high-grade fever, pain, COVID was negative by now. And these are the recent investigations, ESR reducing, HbA1c was 7.4, so we started the oral hypoglycemics also. And knee aspirations was seropurulent for again sent for CS. On 38th day, fever continue, swelling presented over the tibial tunnel, and aspiration was pus from the tibial tunnel side. Still fluid culture showing no growth of the organisms. So this is now ARS question 2. What we do? Just change the antibiotic or lavage and debridement, or go aggressive and removal of graft and all implant and everything.
So the majority goes with debridement and removal of graft.
Yes, so I did exactly the same. So I removed the graft, the culture was still negative, so ID specialist started IV meropenem injection, broad spectrum. And the things were improving. I allowed the tibial tunnel to kept open for the secondary healing because there was a pus discharge from that side. So no fever, general condition was improving, and IV meropenem was given for 3 weeks followed by oral cefuroxime. So now the things were settling down, nothing, there was no foreign material inside. The physiotherapy started gaining range of motion, as well as the oral anti-hypoglycemic drugs were also started. So we think that everything is now settling down. And discharging sinus got the dressing daily on daily basis. It was wound also improving day by day. But still no bug was isolated, so that was the situation. And after 2 months, on 62nd day post ACL, I got a call that there is excruciating pain in the knee, severe night pain, she was not able to sleep. There was no fever, no local sign of inflammation. I took the X-ray, it showed lytic area in proximal tibia. So unfortunately, I don't have the X-ray right now. But I ordered an MRI, and look at this. So this is osteomyelitis of the proximal tibia. Believe me, high-end antibiotics were given for more than a month. All cultures were done, including the tuberculous, atypical mycobacteria, everything normal, but still, this was the picture. So I was a little bit worried, discussed with the patient that this is very unusual sort of infection we are facing, and it requires radical treatment in form of extensive debridement. So this is the detailed MRI. Can you see? Fortunately, femoral side looks okay, but there was a huge amount of the osteomyelitis in the proximal tibia. So, may I ask the panel, expert panel, what should be done at this point of time?
So I think one of the things to be kept in mind is fungal infection, mucor, and other fungal group of organisms, because that falls into the presentation like this. You are giving IV antibiotics, still that much amount of destruction is happening in spite of debridement.
Yeah.
Of course, you're going to tell us, but that is one thing to be kept.
Yeah, this is most unusual. I mean, you don't have any systemic signs which are aggressive signs of pyogenic infection. And it is 2 months down the line, and all of a sudden, one fine day, the pain comes back. It tells us about some kind of pressure symptom in the proximal tibia, which is happening overnight. But as you said, there is no aggressive fever or anything accompanying that pain. So it beats me what infection it could be, but yes, it can be something like fungal or
yes. So the thing is, when we removed the implant and everything, we sent for the fungal cultures also. It was not showing any growth of any fungal organism. So we discussed with the patient, and the plan was to debridement and curettage. Material sent for all these things, as well as histopathology this time, which can show, throw some light. And I used the stimulant granules, these calcium sulfate granules, mixed with the vancomycin, gentamicin, and colistin. So these beads provide high concentration of local antibiotics, prevents biofilm formation, and it also did some dead space management. So the stimulant after extensive debridement, the stimulant granules were kept, and the primary closure of the wound was done after mobilizing the flaps. And I was quite confident that now it can solve the problem. But on 68th day, I got this call from the myologist that, again, it is this KOH, the potassium hydroxide stain, shows few thick, broad, ribbon-like fungal infection, and mucormycosis could be the cause. But still, we cannot give 100% opinion as the culture is not growing, but wait for the histopathology. The next day, we got the histopathology. It confirms the diagnosis of mucormycosis, but still the fungal growth on culture was not possible. So this was the post debridement or recent MRI which showed these beads inside. Now this is a mucormycosis osteomyelitis, and I look at the literature, and it was really scary. There was some reports of mucormycosis infection after ACL reconstruction, And it shows that it requires multiple radical debridements, multiple reconstructive procedures, and few cases of amputation also. So we were dealing with such a drastic infection. Even we don't have the experience of treating in past the mucor. And this is the thing that unless it destroys the bone, usually the diagnosis is delayed. So this was the issue. So what to do now? I was really confused at that point of time. And the issues were, it was a life-threatening and limb-threatening infection. Drug of choice was liposomal amphotericin B, which has a real side effects. Dose has 5 milligram per kilogram per day, given in a central line in 5% dextrose. The renal side effects, hypokalemia, nausea, vomiting. The chemotherapy is very, very, means you can say complications rate is very high. Duration of treatment, 4 weeks IV followed by 3 to 4 months of the oral posaconazole treatment. No experience of treating such devastating complication, and cost, 50 kilogram patient cost 15,000 per day for 4 weeks. So these were the issues. So I discussed with the patients and relatives that we are facing this very unusual and drastic complication. And I don't know really what to do, but I searched to the literature and I called to the Stimulan, the biocomposite company guys in UK, and I just got the confirmation then you can mix the Stimulan beads with amphotericin B. And this was the plan. Ultimately, on the 74th day, we did a radical debridement, extensive debridement, Stimulan granules, biocomposite, mixed with the liposomal amphotericin B, 2 vials, and skin flaps are mobilized and wound closure was done. So this was 80th post-op day. This is after stitch removal, after 15 days. So liposomal amphotericin B started, given for 4 weeks. Every day serum potassium was done. Alternate day serum creatinine was done. And during this course of antibiotics, 4 weeks, liposomal amphotericin B, she was admitted 3 times in the hospital, one for hypokalemia-induced cardiac complication and 2 times severe weakness following the nausea and electrolyte imbalance. So it was a very, without the help of the ID specialist and intensive care specialist, this was not possible to treat such a drastic complication. And after that 4 weeks of the IV amphotericin B on the central line, oral posaconazole treatment was given for 3 months. And this is the, after 4 months of the treatment, and at the 6 months MRI showed complete resolution of the infection. So the lessons learned, thorough pre-op evaluation is absolutely mandatory. Extremely important to find out the bug, because without that, I think it is impossible to treat the infection. And it's a teamwork, microbiologist, anesthesiologist, ID specialist, physio. And you have to keep very close observation once complication happens. And most important part, counseling of patient and relative, what I found. Case is open for the discussion.
Thank you, Dr. Kalpesh.